Welcome to the Deep Dive. This is the show where we take source material articles, research, commentaries, and really pull out the key insights for you.
Yeah, we try to get past the jargon and give you the surprising facts, the connections you might miss, basically make complex stuff accessible.
Exactly. Think of us as your guides to understanding the deeper story.
And hopefully give you those aha moments along the way.
For sure. And this time, Deep Dive number 17, we're talking ketamine. We're diving into the, frankly, incredible and kind of wild story of this one molecule.
Ketamine. You've probably heard the name, maybe linked to depression treatment, maybe other things. Its history is, well, it's got twists. 60 years of them.
It really does. And our guide for this exploration is a really insightful recent commentary. It just came out this year, 2025.
Right. It's titled The 9 Lives of Ketamine. From CI 581 to present-day clinical application commentary on Domino et al. The author is Evan D. Karash, and it was published in Clinical Pharmacology and Therapeutics. Great piece.
Yeah, it really lays it out clearly. So we're giving full credit there. Our mission today, using that commentary as our lens, is to unpack how ketamine, which actually started as CI 581, went on this really long and complicated journey.
And understand why it's had such a lasting and honestly revolutionary impact on medicine and even beyond.
So if you're curious about ketamine for depression, maybe you've read about it, or you're just fascinated by how a single drug can have so many different lives over the decades, this deep dive is definitely for you.
We'll walk you through it step by step, pulling out the key moments from this expert analysis.
Okay, let's jump in. Where does this story really begin?
Well, you have to go back to the science, the very first publication. The commentary points to a paper from May 1965, also in Clinical Pharmacology and Therapeutics.
Okay.
It was called Pharmacologic Effects of CL 581, a New Dissociative Anesthetic in Man, by Domino, Chodoff, and Corson. That's the starting gun.
And this wasn't just like any old paper, right? The commentary really stresses its importance.
Oh, absolutely. It was the first clinical report on this molecule, the first time it was studied in humans. Period.
Wow, first in human.
Yeah. And get this, the commentary mentions it became the most cited paper from that journal for the entire decade of the 1960s.
That's huge. Tells you it made waves immediately.
Instantly. But CI 581, the molecule they were studying, its story actually starts a bit earlier with what the source calls its older sibling.
An older sibling molecule.
Yeah, CI 395. Synthesized back in 1956 at Park Davis Labs. You probably know it by its other name. Phencyclidine.
Wait, phencyclidine? As in PCP.
That's the one.
So ketamine, the drug now used for depression, is related to PCP, the street drug. That's surprising.
It's a core part of the origin story. PCP actually showed some promise initially, good anesthetic properties in the lab.
But there's always a but, isn't there?
Big but. In humans, it caused really severe prolonged emergence delirium, like people waking up totally confused, agitated, sometimes for days, plus these awful feelings of sensory deprivation.
Yikes. Not ideal for recovery.
Not at all. The source is pretty blunt. It says PCP was seen as a great model for schizophrenia because of the effects it produced, but absolutely not suitable for human anesthesia. Full stop.
Okay, so PCP was a non-starter clinically.
Yeah.
What did Park Davis do? Try to fix it.
Exactly. The research goal became find a short-acting version of TCP. The thinking was maybe if it clears the body faster, you avoid that horrible, long-lasting delirium.
Makes sense.
Uh-huh.
And that led them to CI 581.
Yep. A chemist named Calvin Stevens at Wayne State University in 1962 synthesized a whole series of related molecules. Park Davis picked CI 581 out of that batch for clinical trials.
In CI 581 itself, the molecule?
Yeah.
Was it a big change from PCP?
Chemically. Not huge. The source gives the name 2-chlorophenyl-2-methylaminotheclohexanone. It highlights it was a relatively simple structural tweak, but that small change made a big difference, especially in how long it lasted.
Shorter duration, like they wanted.
Exactly.
So where did they first test it on people? The commentary mentions a place that kind of makes you pause today.
Yeah, it does. The human trials started in '64. One of the sites mentioned was the Park Davis Clinical Research Unit at Michigan State Jackson Prison.
Testing on prisoners.
Wow. The author explicitly calls it a sign of the times that would not happen today. And rightly so. It really shows how much research ethics have changed.
Absolutely. Unthinkable now.
But interestingly, the commentary adds this little historical footnote. That specific research, problematic as it was, actually ended up serving as a kind of prototype for the later development of ethics committees specifically focused on regulating research in prison populations.
A strange silver lining from something ethically dubious.
A very strange twist, yeah.
Okay, so they're testing CI 581 in humans, including this prison setting. What did that big 1965 paper actually report? What were the findings?
Well, first off, it worked. It was an effective pain reliever and anesthetic, and the effects scaled with the dose.
Good start. What made it stand out from other anesthetics at the time? This must be where the excitement came from.
This is key. Several major advantages. Rapid onset worked fast. Relatively short duration of unconsciousness, which was the goal. And crucially, minimal or no negative effects on the heart, blood pressure, or breathing.
That's huge for anesthesia. Respiratory depression is always a big worry.
Exactly. And it didn't seem to harm the kidneys or liver either. No organ toxicity. The commentary stresses that these things fast on, short duration, safe for heart and lungs, safe for organs, were massive pluses compared to what else was available in the mid-60s. A lot of other drugs carried big risks.
It also affected brain waves differently.
Yeah, unique EEG effects too, but maybe the most dramatic finding wasn't about being totally knocked out.
Right, you mentioned that earlier. Profound pain relief without unconsciousness.
Yes, that was really striking. Patients could be in this weird state, not fully under, but totally insensitive to pain. This immediately suggested, as the commentary notes, that you could potentially use it alone for painful procedures where maybe you didn't need or want full general anesthesia or where keeping the patient breathing well was critical.
Okay. Effective, physically quite safe, unique analgesic properties. Sounds amazing. But the PCP connection looms. Did it have weird mental side effects too? The source calls it the most unusual effect.
Oh, yes, and this is where we get the psychic syndrome. It definitely had its own unique mental landscape.
What were people experiencing?
All sorts of strange stuff. Feelings of numbness, like they didn't have arms or legs, or even felt like they were dead, even though they could still feel touch.
That's bizarre. Feeling dead but feeling touch.
Right, and big shifts in mood, perception, body image. Some got anxious, aggressive, others withdrawn. Feelings of being estranged, isolated, hostile, apathetic, drowsy, drunk, or these sort of hypnogenic, dreamlike states.
A real grab bag of altered states.
Yeah, and the commentary points to the most vivid ones. Actual dreamlike experiences or sometimes outright hallucinations, often scary ones. People described it as being like death or like being in outer space.
Agree. Being in outer space. That phrase really captures that sense of
There you go.
detachment.
It does. So you have this mix. Potent pain relief, relative physical safety, and these profound, strange mental effects. It clearly wasn't typical anesthesia.
So they needed a new name for it.
Exactly.
Yeah.
Domino and his team recognized this drug's actions, analgesia, anesthesia, keeping vitals stable, plus these weird dissociative brain effects needed new terminology.
And that's where dissociative anesthesia comes from.
That's the term they proposed. The commentary gives two origin stories, actually. One is the clinical idea. Patients seemed disconnected from their surroundings, maybe a functional dissociation between higher brain areas and the emotional limbic system.
And the other, more personal.
Yeah, an anecdote from Dr. Domino himself. He said he was telling his wife about how subjects felt disconnected from everything, and she suggested calling it dissociative.
Huh. Love that. A key medical term born from a chat at home.
Adds a nice human touch, right?
Right.
And the source notes that ketamine, the name itself, comes from ketone, and amine in its structure is still the only drug in this class, the only dissociative anesthetic.
So despite these, strange experiences, it got a lot of praise early on.
It did. Because of those physical safety advantages, some people were incredibly enthusiastic. The commentary quotes someone calling it the most important advance in the symptomatic treatment of pain since the discovery of aspirin.
Wow. High praise indeed. So Park-Davis pushed ahead for approval, even with the psychic stuff.
Yeah, the source says, maybe surprisingly to the original researchers, Park-Davis decided the pros outweighed the cons, and it got U.S. FDA approval in 1970.
And one last interesting tidbit about Dr. Domino.
Yeah, the commentary points out something not widely known. Domino, who was so crucial to this research, wasn't actually an anesthesiologist. He was a pharmacologist and psychiatrist.
Interesting. Shows how different fields came together here. Okay, so that's the origin. Linked to PCP, discovered as this uniquely safe anesthetic analgesic, but with bizarre side effects, leading to the term dissociative. Now, let's talk about its many lives, as the commentary puts it.
Right. The author, Karash, uses this great metaphor. Ketamine has had these distinct waves of interest and use over the decades. You can actually see it in graphs of research publications over time, clear peaks and valleys.
So life number one, After that 1970 approval,
That was the honeymoon period, basically, early 1970s, initial high hopes, especially among anesthesiologists.
what drove that initial excitement? Remind us of those key attractive features.
It was that whole package. Powerful pain relief, awake or asleep. Good amnesia, that amazing cardiovascular stability, lack of breathing suppression, keeping airway reflexes intact, no organ toxicity.
And it was useful across the board.
Pretty much. Infants, kids, adults. Especially valuable, the source notes, in patients who were already sick or unstable, or other anesthetics were too risky. Its role in the Vietnam War is specifically highlighted invaluable for battlefield trauma because it was effective and kept vital signs stable in dire situations. Still used that way today in trauma centers and on battlefields.
A versatile drug with a usually large margin of safety, as the source says.
Exactly. Big safety advantage compared to many drugs back then. People thought it might even replace inhaled gases in some cases, kind of foreshadowing modern IV anesthesia techniques. Its importance was recognized globally. It got on the WHO list of essential medicines in 1984.
Okay, so bright start. But the many lives thing implies that didn't last forever. What happened next? Life number 2 sounds like a downturn backlash. Dormancy.
Yeah, that initial wave crested and broke. The commentary mentions how controversial ketamine quickly became.
Why the controversy? Why did the enthusiasm fade?
It really came down to those mental side effects, the psychotomimetic stuff, the psychic syndrome, fear of patients having bad dreams, hallucinations, freaking out during emergency department. It made the drug anathema, the source says, just totally undesirable to a lot of anesthesiologists.
So the weirdness outweighed the safety benefits for many.
For routine use in many settings, yes. It got a bad reputation. Using it frequently could even make you a bit of a pariah among peers, according to the commentary. The psychological unpredictability was a major hurdle.
So it fell out of favor. But obviously, the story picks up again. The commentary talks about key scientific discoveries, sentinel events that sparked new lives for ketamine. What was the first?
The first was figuring out how to manage those side effects better. The discovery was that benzodiazepines, drugs like Valium or midazolam, used for sedation and anxiety, could significantly blunt the psychotomimetic effects.
Ah, so giving a benzo along with ketamine made the recovery smoother.
Much smoother. Reduce the emergence delirium, the nightmares. The commentary says this made ketamine slightly less undesirable, kind of damning with faint praise, but it was a practical step that made it more usable again.
Okay, step 1. Manage the side effects. What was the next big breakthrough? This sounds more fundamental.
This was huge. For like the first 20 years, nobody really knew how ketamine worked at a molecular level. They knew what it did, but not why.
And then they figured it out.
Well, a key part of it. In the mid-1980s came the discovery that ketamine is a non-competitive antagonist of the NMDA receptor in the brain. This was a massive sentinel event.
Okay, unpack that. NMDA receptor. Antagonist.
Right. NMDA receptors are proteins on brain cells, crucial for excitatory signaling how neurons talk to each other, involved in learning, memory, brain plasticity. An antagonist blocks the receptor. So finding out ketamine blocked this specific important receptor gave a concrete biological target.
And that discovery had ripples.
Big ripples. The commentary says it didn't just revive interest in ketamine itself, it helped to launch the entire field of NMDA neurobiology research. Scientists suddenly had this tool, ketamine, to probe what these receptors did.
But wait, the source also says we still don't fully understand how ketamine works, even after finding the NMDA link.
That's a really important point the commentary makes. Yes, NMDA antagonism is key, but it's not the whole picture. The mechanisms behind all its effects, especially the antidepressant ones, are still considered incompletely elucidated. Why? Because it turns out ketamine messes with a lot of other things in the brain, too.
It's not a magic bullet hitting just one target.
Far from it. Subsequent research found it interacts with a whole host of other receptors and ion channels. The commentary, drawing from tables often found in these papers, lists a dizzying array. HCN channels, voltage-gated calcium, sodium, potassium channels, opioid receptors, AMPA, GABA, serotonin receptors, acetylcholine receptors, neurokinin-1, norepinephrine transporters, even enzymes like cholinesterase and nitric oxide synthase, dopamine D2. I mean, it's complicated.
Wow. That's incredibly nonspecific. It's like hitting the brain with a pharmacological scattergun.
Kind of, yeah. Modern drug discovery often aims for laser precision, one target. Ketamine is the opposite. This promiscuity, hitting multiple targets, is likely why it has such a broad range of effects, good and bad, and figuring out which target does what is still ongoing.
Okay, so managing side effects, discovering the NMDA target, and others. What was discovery number 3?
This has to do with its shape's stereochemistry. Like your hands, some molecules come in mirror image forms called enantiomers. Ketamine is usually made as a mix of two, R-ketamine and S-ketamine.
And scientists could separate them.
Yeah, they figured out how to isolate R and S and test them individually. They found some differences in potency and effects.
Was the idea that maybe one form was the good one and the other the bad one?
That was definitely the hope. Could they separate the anesthesia or pain relief from the psychic stuff by using just one enantiomer? The commentary says that perfect separation didn't quite happen. There were differences, but not a totally clean split.
But studying them was still important.
Absolutely. It sparked way more interest in ketamine's stereochemistry specifically and contributed to the whole field realizing how important stereochemistry is in general for drug development. Mirror images can act differently. And, crucially, this work eventually led to the approval of just S-ketamine for certain uses, which we'll get to.
Got it. So benzos, NMDA, other targets, stereochemistry. What was the 4th key discovery?
This was about what happens after ketamine gets into your body. It's metabolites. Your body breaks drugs down, right?
No, metabolism.
So researchers identified the molecules ketamine gets turned into. And the key finding was many of these metabolites are also pharmacologically active. They do stuff in the brain, too.
So it's not just the original drug working, but its breakdown products are active as well.
Exactly. Adds another layer of complexity. This generated a whole new wave of interest. Could one of these metabolites be developed as a drug itself? Maybe it would keep some benefits like antidepressant effects, but have fewer side effects than ketamine. That research is still very much alive.
Fascinating. Looking for a cleaner version from the breakdown process. Okay, so these 4 big discoveries, managing side effects, understanding targets, separating enantiomers, active metabolites, they set the stage for another comeback, right?
They did. Starting around the mid-1990s, the commentary shows ketamine saw this dramatic resurgence, especially back in anesthesia and pain management. The publication trends shoot up again.
Back in favor in the field that initially rejected it.
Yeah, but used differently.
Yeah.
Often as part of a multimodal approach, combining it with other drugs for anesthesia or pain relief, not necessarily as the sole agent. And increasingly used specifically for pain, both acute post-op pain and chronic pain.
What drove that resurgence in pain management specifically?
The commentary points to one massive factor, the opioid crisis. As the devastating impact of opioid overprescription, addiction, and overdose became undeniable, there was immense pressure to find alternatives for pain.
So with negative press on opioids and new guidelines urging doctors to cut back.
Exactly. Clinicians desperately needed effective non-opioid options. And there was ketamine, with its known potent analgesic effects and relative safety, especially regarding breathing, compared to high-dose opioids. Looked pretty good again.
The commentary uses strong language here about a pendulum swing.
It really does. It says the ketamine pendulum has swung completely in anesthesia and pain. Opioid-sparing techniques are now de rigueur standard practice. And ketamine use in these settings is now ubiquitous. Basically, it's everywhere.
From anathema to ubiquitous. That's quite a turnaround, driven, sadly, by the need created by the opioid epidemic.
A stark example of how a public health crisis can totally reshape how an existing drug is viewed and used.
Now, alongside these medical lives, the source doesn't shy away from the darker side, the unfortunate parallel life ketamine has had.
No, it addresses it directly. Ketamine became and remains a drug of abuse. That's part of its story, too.
Special K.
Right. Used recreationally, outside medicine. The source mentions people ingest it, inject it, snort it, even smoke it, seeking those dissociative effects, sometimes called K-land or the K-hole.
And this led to legal controls.
Yes. Because of the abuse potential, it was made a Schedule III controlled substance in the U.S. back in 1999. Still available medically, but with restrictions. You have to acknowledge that aspect.
Okay, so origin, initial hopes, backlash, comeback via science and the opioid crisis, plus the abuse issue. That brings us to the most recent and arguably the most explosive life for ketamine.
This is the antidepressant revolution, starting really in the mid-2000s. The publication trends graph in the commentary just goes almost vertical here. It's all about using ketamine for treatment-resistant major depression.
And the source notes something surprising about this, that the antidepressant potential was seen way earlier.
Yeah, this is wild. The commentary highlights that hints of antidepressant effects were actually observed back in the initial 1960s testing. But nobody pursued it then. The focus was purely on anesthesia.
Hidden in plain sight for 40 years.
Pretty much. Shows how scientific focus shifts, right? An old drug gets a completely new life when the context changes.
What makes ketamine so revolutionary for depression compared to standard antidepressants like SSRIs?
Speed and efficacy, mainly. Traditional antidepressants, as the commentary notes, often work incompletely, especially in severe cases, and they take weeks to months to kick in, if they work at all.
Weeks to months, okay. And ketamine?
The breakthrough finding is that subanesthetic doses lower than for anesthesia can produce rapid and robust antidepressant effects. We're talking hours to days.
Hours to days. That is fundamentally different. For someone severely depressed, non-responsive, that's potentially life-saving speed.
Absolutely. The ability to potentially lift severe depression and suicidal thoughts that quickly is the game changer. The commentary cites key early trials like Berman et al. In 2000 and Zarate et al. In 2006 using IV ketamine as really launching this revolution.
And the impact on psychiatry as a field.
Huge. The commentary calls it a breakthrough discovery that revolutionized the field. It changed treatment approaches, demanding faster options, and it changed the basic understanding of depression's biology, pointing towards rapid synaptic changes rather than just slow neurotransmitter adjustments.
And this is the life that connects to what many people are hearing about now, the rise of ketamine clinics.
Directly. That research explosion and the dramatic clinical results are why you see all these clinics opening up offering IV ketamine or other forms, specifically for treatment-resistant depression.
Which leads logically to the next step, formal approval for depression, the echo of this life, the source calls it.
Exactly. The evidence got strong enough to pursue FDA approval specifically for depression.
And this ties back to the enantiomers. It wasn't the regular ketamine mix that got approved.
Correct. The FDA-approved version for depression is the single S plus enantiomer, marketed as esketamine.
And it's given. How? Not IV for the approved version.
Right. It's a nasal spray. The commentary explains why. Repetitive IV isn't practical for long-term outpatient treatment, and taking it orally doesn't work well because of poor absorption and liver metabolism. Nasal spray was a way to get it into the system effectively without needles.
So, esketamine nasal spray got the green light. When and what's the market like?
Research on esketamine specifically ramped up in the mid-2010s. The FDA approved it in 2019 for treatment-resistant depression, and later added an indication for depressive symptoms in people with major depression having acute suicidal thoughts or actions.
And the scale of this market now? Commentary gives some numbers.
Big numbers. Nasal esketamine sales alone were projected over $1 billion for 2024. The overall U.S. ketamine clinics market using various forms, often off-label, was estimated at $3.4 billion in 2023, potentially hitting $6.9 billion by 2030. The commentary expects these steep upward curves to continue.
Just staggering. From outer space hallucinations in the 60s to a multi-billion-dollar depression treatment today. What a ride.
It really underscores how unpredictable drug development can be. This molecule just keeps surprising everyone.
So looking back at this whole journey, what does the source say ketamine teaches us? It calls it a pharmacologic agent provocateur. What's that mean here?
It means it stirs things up, it challenges the rules. Ketamine, the commentary argues, fundamentally challenges some classic principles of pharmacology.
Like what principle specifically?
The big one is exposure response. The idea that how strong a drug's effect is and how long it lasts should match how much drug is in your body. More drug, more effect. Drug gone, effect gone.
Makes intuitive sense. But ketamine breaks that rule, particularly for depression.
Big time. Its antidepressant effects can last for weeks after just one dose. But the drug itself, and even its active metabolites, are gone from your blood in hours. The clinical benefit is totally divorced from, it completely outlasts the drug's presence.
The effect sticks around long after the drug itself has vanished. What does that imply?
It implies the drug isn't just working while it's physically there. It must be triggering longer-lasting downstream changes in the brain. Things like altering brain circuit activity, changing the connections between neurons, synaptic plasticity, maybe even altering gene expression. It's like flipping a switch that resets something rather than just holding a button down.
So it's making us rethink how drugs can work, especially in the brain. triggering lasting biological changes.
Exactly. And the commentary stresses how influential this has been. Modern pharmacology owes a lot to Domino and his colleagues and this weird molecule. Entire research careers have been built trying to figure it out.
Which leads the author to pose this really fascinating, almost unsettling question at the end.
Yeah, this is the kicker, thinking about drug discovery now. The question is, if CI-581, the original molecule, was synthesized today, would it even get approved? Would a drug company even develop it past the very early stages?
Why might it fail today's standards? What's the argument?
The author lists several reasons why it's kind of the opposite of what's often sought now. It's not super potent by modern metrics. Its mechanism is still messy and not fully understood. It hits lots of targets. Its effect totally disconnects from its concentration in the blood. It has active metabolites, adding complexity. It has known abuse potential. And it's not specific. You get the dissociation and psychic effects along with the pain relief or anesthesia at similar doses. Hard to isolate one effect.
So putting all that together, messy mechanism, weird timing, active metabolites, abuse risk, side effects. What's the author's guess?
The bet, as the commentary puts it, is that it would likely be killed early in today's drug development process. It just doesn't fit the modern ideal of a clean, predictable, potent single-target drug.
It has huge implications, doesn't it?
Massive. Think about all the patients helped by ketamine over 60 years. Anesthesia, trauma, pain, now depression. If it were discovered today, under current paradigms, would they ever have gotten access to it?
And are we potentially missing other ketamines today? Are we too focused on clean drugs and maybe discarding unconventional but potentially powerful molecules because they're too complex or don't fit the mold?
It's a really critical question for the field. Ketamine's story is a powerful reminder that sometimes the most valuable medicines are the ones that break the rules.
And the source loops back to Dr. Domino himself, reflecting in 2010.
Yeah, his questions from back then are still spot on. Why has this drug survived? What can we learn from the past? Can knowledge about ketamine guide us to relieve pain and suffering? What are its potential new therapeutic uses?
That last question about new uses obviously resonates hugely with the whole depression story. It's still unfolding.
Absolutely. The journey isn't over, which brings us towards the end of this deep dive.
What a journey it's been. From a relative of PCP to a revolutionary but controversial anesthetic, facing backlash. Then revived by science and the opioid crisis for pain, dealing with abuse issues, and now exploding as this rapid antidepressant. It really has had, 9 lives.
A story full of surprises, contradictions, constantly challenging how we think drugs work.
And we navigated it all thanks to our source. The commentary, The 9 Lives of Ketamine. From CI-581 to present-day clinical application commentary on Domino et al. By Evan D. Karash in Clinical Pharmacology and Therapeutics 2025. Really excellent framing of the story.
And we'll leave you with that final thought prompted by the commentary. Ketamine, with its messy profile, probably wouldn't make it through drug development today. So what does its unlikely 60-year success tell us about the kinds of potentially breakthrough drugs we might be overlooking right now because they don't fit our current expectations?
Something to really chew on. That concludes this deep dive into the remarkable story of ketamine.